Welcome to eGurukul. Myself, I am Dr. Ramyasri. I teach obstetrics and gynecology. So we are going to discuss about the genital prolapse clinical case in this session. So let's start with the questions. Let's start with the case. So in this case, I'm going to teach you how do we present this case, what will be the history, chief complaints. Next, how do we examine the prolapse? How should we investigate a case of prolapse? How should we treat the case of prolapse? So these will be discussed in this session. So let's start with the session, starting with the patient's profile. So Mrs. X, 60-year-old female, who is an illiterate and a daily wage worker who lives in Noida. Her husband is Mr. X, around 75 years age, who is also a daily wage worker, and they belong to lower socioeconomic status. So the first thing I want you to observe in the history, which I repeat for all cases again and again, is so although I've written it as a education, occupation, location, but when I am presenting, I present it as a single line. The flow is very important when you are presenting a case, right? So next, what is the importance of age here in the genital prolapse case? So when they are postmenopausal status, the tone of the muscles is lost and that leads to the prolapse, right? Now do and another positive point in this just her patient profile is she's a daily wage worker, so she might be lifting heavy weights. Lifting heavy weights is also acts as a risk factor for these patients, right? So there are 2 points which I have taken from this patient's profile. Now husband's age or husband's occupation is not much important to me, but yes, as a routine, I have just written it. Okay. So no need to stress much on the husband here in the prolapse case. So her chief complaint is mass coming out of vagina since 7 years. History of presenting illness. Patient has first noticed the mass 7 years back, which is gradual in onset, progressively increased to the current size. It comes out on straining, coughing, lifting heavy weight, and squatting. Patient has to reposit it. The history of low backache and lower abdominal pain on and off. There's history of chronic lifting weight. So once I'll present the entire history, chief complaints to you, and then we will discuss each and every chief complaint. Okay? There's no history of dribbling of urine on straining, coughing, or laughing. No history of difficulty in initiating micturition, frequency, urgency, burning, or painful micturition, or incomplete voiding. There's no history of difficulty in defecation, initiation, feeling of incomplete sense of emptying, fecal incontinence, or splinting or hard stool passage. No history of bleeding per vagina. So all this is negative history. I've written my positive history first, followed by I'm telling you the negative history. So this is how even you also have to write and present. No history of chronic cough or constipation. No history of discharge or bleeding per vagina. No history of postcoital or postmenopausal bleeding. No history of weakness or abnormal sensation of loss of sensation in lower limbs. No history of surgical or non-surgical treatment for the problem. No history of smoking. No history of chronic steroid therapy, and no history of mass per abdomen. So these are my chief history of presenting illness. So let's elaborate and understand each history. Okay. So my patient 65-year-old 60-year-old has come to you with mass coming out per vaginum since 7 years, right? She has noticed the mass 7 years back, and now it has gone to the current size, whatever size she has. She has complaints of, so 7 years is a pretty long time, right? She complains of mass coming out only on straining or coughing or lifting heavy weight. So it is a reducible mass. Point number one, the mass is reducible. If in my history the patient would have been presenting to you with irreducible mass, then it means that it's a prolonged history, it's a prolonged problem, and there might be either edema of the mass, because of which the mass is not able to reduce, right? So it is a long history, long standing, and it is not, there might be congestion, edema, or hypertrophy of the tissues, which is preventing the reducibility. But in our case, it is reducible. But she has to repose it back. So they are coming out on raised intra-abdominal pressure. It doesn't go by itself, but she has to reposit it back. So that is the first thing. So whenever you are presenting a mass per vaginum, point number one is you have to describe the time period of the mass, from how long that mass is present and how is the progression of the mass. Next point, what you are telling is you have to highlight whether the mass is reducible or not reducible. So, first is the time duration which you have to mention. Second is whether it is reducible or irreducible. When it becomes irreducible, it means the severity of the mass is more, because it tells that the mass might be edematous, congested, as well as hypertrophy of the tissues, which is preventing the mass to go back. Here, mass is reducible, but she has to deposit it back. So, second point, speak about the reducibility. Third, any other positive history I'm writing here. So, for example, here the patient has come to me with history of low backache. Now, very favorite question of all examiners will be, why does she have a low backache? So, whenever if you're suspecting this to be a genital prolapse, so because of the genital prolapse, when the cervix and uterus is trying to come down, the ligaments get stretched. The McEnroe ligament gets stretched, and that leads to chronic backache. So you have to tell that the chronic backache is due to stretch on the ligaments, stretch on McEnroes. And she also present to you here with lower abdominal pain on and off. History of chronic lifting weight. So, history of chronic lifting weight is also one of the reason to push the intra-abdominal organs outside. So, this acts one of the risk factor for the prolapse, right? So, apart from this, you should also have the history of decubitus ulcer. See, they can also have, it's a prolonged mass, so there's always high chance of them having the decubitus ulcer. So, to elicit the findings of decubitus ulcer, you should ask history of white discharge. So there can be profuse discharge coming from the ulcer, or there can be a history of bleeding. So they can present you with postmenopausal bleeding, right? Next, they can also present you with the postcoital bleeding if there's an ulcer. So if you don't have, at least write it that no history of white discharge per vaginum or postmenopausal bleeding or postcoital bleeding. If they ask you why did you ask these, because then you know this you can put it in the last, actually you don't require to tell here itself. So after the, see, after I've told per se about the mass, then is the negative history. So in the negative history, my how did I divide the negative history is, first, initial points all are regarding the, to rule out cystocele. Next, I have taken the negative history to rule out rectocele. Next, I have taken history of, so any history, no history of discharge or bleeding per vaginum. So this is for the, or postcoital or postmenopausal bleeding. This is for the decubitus ulcer. Now, why did I go cystocele, rectocele, and decubitus ulcer is, and then I have taken history, negative history, to rule out the risk factors for prolapse. To rule out the risk factors for prolapse. So I always tell you your history should be beautiful and organized. Yes, I know you're going to take a history from your patient. So when you're taking history from your patient, your mind should know these are the things I want to know from the patient. So सबसे पहले what are you doing? यू आर ट्राइंग टू फाइंड आउट और एक्सट्रैक्ट द इंफॉर्मेशन कि मास कैसा है. तो मैं आपको बता रही हूँ कि कौन से पॉइंट्स के ऊपर लेना है, क्योंकि बिकॉज all patients might not have the same history. You are going to take my format and you're going to take your own history from the patient. So you should know what are the key points I should take to extract the history from the patient. So this is my organization or simplifying it for you to how to take a history. So what did we do here? So first, time from how long this mass is present and what size it has come. Second, whether it is reducible or irreducible. Then take any other positive history which you have. Negative history में take the history to rule out the cystocele, take the history to rule out the rectocele, take the history to rule out the decubitus ulcer, take the history to rule out the risk factors. When you start with this, when you are presenting, they can either stop at cystocele, they can either stop at rectocele, they can either stop at postcoital or postmenopausal bleeding also, or they can stop at risk factors. So it just depends on where they can stop, you can never assess, right? So let's start in the negative history from cystocele. So what is the negative history I took for the cystocele, or chief complaints which you will have when you have a cystocele are dribbling of urine on straining, coughing or laughing. So this means I am trying to ask for stress incontinence. So for cystocele, the chief complaints we'll have are, so if you are able to tell the complaints and if you are able to tell why did I take and how did I rule out, they'll be super impressed by you. So with cystocele, the chief complaints which we have are stress incontinence. So why do we have stress incontinence here? So normally bladder neck and proximal urethra will be above the urogenital diaphragm. Normally, the bladder neck and proximal urethra will be above the urogenital diaphragm. But in prolapse, this bladder neck and urogenital diaphragm descends, bladder neck and proximal urethra descend below the urogenital diaphragm. Descend below the urogenital diaphragm. So, as they descend below the urogenital diaphragm, what is happening? They might have complaint of stress incontinence. Let's understand why. Now, whenever there is raised intra-abdominal pressure, this urogenital diaphragm will close. This urogenital diaphragm will immediately close. And as the urogenital diaphragm closes, no urine comes out. Now, when the proximal urethra and bladder neck has descended below the urogenital diaphragm, when there is rise in intra-abdominal pressure, urogenital diaphragm will close, but the urine in the proximal urethra and bladder neck will come out. I repeat, one of the chief complaint is stress incontinence. Why are we having stress incontinence in cystocele? The stress incontinence in cystocele is due to urethral hypermobility. So what do I mean by that? Here in prolapse, when proximal urethra and bladder neck descends below the urogenital diaphragm, so whenever there is rise in intra-abdominal pressure, the urogenital diaphragm will close, but the urine in the proximal urethra and bladder neck keeps on leaking. And this happens only when there's rise in intra-abdominal pressure. Matlab when she's coughing, laughing. So one of the symptom is stress incontinence. Okay. Now one more point, guys. When you have a large cystocele, there won't be stress incontinence, because large cystocele you'll have a problem of initiation of micturition. So this problem is associated initially when you have a small cystoceles. Okay. So next complaint which we have put forward, which I have taken here, is difficulty in initiating micturition. Now let's understand why will they have difficulty in initiating of micturition. First and foremost, when do you see cystocele? When do we have cystocele? So normally the upper two-third of vagina is related to bladder. Upper two-third of vagina is related to the bladder. So between the bladder and upper two-third of vagina, you have vesico-vaginal fascia. You have vesico-vaginal fascia. Whenever there is a defect in this vesico-vaginal fascia, upper two-third of the bladder pouches into the vagina, which you call it as cystocele, right? So cystocele is due to defect in the upper two-third of vagina. Defect in the upper two-third of vagina. So cystocele is due to defect in the upper two-third of vagina. Upper two-third of the vesico-vaginal fascia. Urethrocoele is when lower one-third of the vesico-vaginal fascia is defective and it pouches into the vagina. You call it as urethrocoele. So upper two-third anterior wall defect will lead to cystocele. Lower one-third anterior wall defect will lead to urethrocoele. So can you observe there will be a pouch? There will be a pouch. So urine will start getting accumulated into this pouch. Urine will start getting accumulated into this pouch, right? When you have a huge cystocele, urine will completely go in that pouch. So when the patient is trying to initiate micturition, all the urine is in this pouch. So how will she able to pass urine? She will not be able to pass urine. So there will be, when there's a huge cystocele, as all urine is diverted into the pouch, they'll have difficulty in initiation of micturition. Next is, even if she wants to pass the urine, so as she is not able to initiate the micturition, so she'll strain. When she strains to pass urine, instead of urine coming out, urine will further go inside the pouch. So on straining, stream of urine further decreases. And pouch deepens into vagina. And pouch deepens into vagina. So what she has to do? She has to correct this pouch. She has to correct this pouch digitally in order to pass the urine. So she has to digitally correct the pouch in order to pass the urine. Okay. Next, as the urine is getting accumulated here, so there is urinary stasis. This urinary stasis will lead to UTI. And the symptoms of UTI will be increased frequency of micturition, burning sensation, okay, right? Next, when she sleeps in the night, the pouch gets corrected. Not only in the night, anytime. So whenever she's lying down, the pouch will get corrected. So this pouch is there, no? This will become Sida. As the pouch will become Sida, or the pouch gets corrected, as the pouch gets corrected, the urine from the pouch will come out. And as the urine from the pouch will come out, she'll have increased micturition. So she'll also have one more complaint of nocturia. So these are all the chief complaints of cystocele which we have taken in the history. So yes, and as urine is getting accumulated in the pouch, so she'll also have symptoms of incomplete voiding. So patient with prolapse will sing, woman with prolapse will sing, जुदा होके भी तू मुझ में कहीं बाकी है. So although she has passed urine, still there is some amount of urine left inside, right? So जुदा होके भी तू मुझ में कहीं बाकी है, right? So those are all the symptoms of cystocele. So I repeat the symptoms and I hope you all understood reason for each of the symptom, right? So what were the symptoms? Stress incontinence, difficulty in initiating micturition because of the pouch, UTI leading to frequency, urgency, burning or painful micturition, and as some amount of urine left inside the pouch, they'll have incomplete voiding, right? Next, symptoms of rectocele. Very similar to the cystocele. In rectocele also, you're developing a pouch. So when do we have rectocele? So posterior vaginal wall defect will lead to rectocele. Posterior vaginal wall defect will lead to rectocele. Upper one-third defective, it leads to upper one-third of the posterior vaginal wall defect will lead to enterocele. Middle one-third posterior vaginal wall defect will lead to rectocele. Lower one-third posterior vaginal wall defect will lead to deficient perineum. Okay. So now again, what will be the chief complaints due to rectocele? Now, if your patient gives any of this history, it means the patient is having rectocele, guys. Okay. So here the patient has presented to us as what are the complaints which a rectocele patient will give you is again difficulty in initiation of defecation. Why? Because the fecal matter is in that pouch. It's difficult for us to push that and initiate the defecation. So how will the patient defecate? Whenever the fecal matter is coming into the pouch, so when she's straining to pass the stools, it won't come out. So she has to digitally splint or push that pouch to pass the stools out. So she has to do digital splinting to pass the stools, very classical for rectocele. And they'll also have feeling of incomplete emptying because some amount of stools are still left in the pouch. Okay, so this will be the complaint for the rectocele. Difficulty in initiation of defecation, feeling of incomplete sense of emptying, and digital splinting. So they can also have fecal incontinence and hard stool passage. So no bleeding per vaginum or discharge per vaginum or post-coital bleeding or post-menopausal bleeding. I'm giving you this history to rule out decubitus ulcer. Whenever you have a long-standing prolapse, it's very obvious that because of the venous congestion, why do we have decubitus ulcer? So decubitus ulcer is seen in the dependent part of the prolapse mass. So usually it is seen on the posterior lip of the cervix. Okay. Now why do we have it? It's because of the venous congestion leading to venous stasis and ischemic ulcer. Treatment is you have to reposit the ulcer back and put a tampon so that there will be good venous drainage. Right? So as there is an ulcer, there can be discharge coming out, there can be blood coming out, and the bleeding might increase after a coitus. So that's why no history of post-coital bleeding. Next. So why did we ask the history of chronic cough or constipation? So these act as a risk factors to raise the intra-abdominal mass and cause the prolapse. So what are the risk factors? Chronic cough and constipation, chronic steroid therapy, mass per abdomen, smoking, all this acts as a risk factor. Raised intra-abdominal pressures are due to chronic cough, constipation, and abdominal mass. It can be a huge fibroid or ovarian cyst which is pushing the uterus and cervix outside. Why history of smoking? Smoking also leads to urogenital atrophy and can lead to prolapse. Chronic steroid therapy again decreases the tone of the muscles, leading to the prolapse. Okay, so that's the reason we have asked. Surgical treatment or non surgical treatment, we should be aware whether they have done any, whether it's a recurrence or whether it's a primary prolapse, right? And weakness, abnormal sensation, or loss of sensation in the limbs. Here, it could be due to diabetic neuropathy leading to the decreasing the tone. But normally, this is more regarding the weakness and lower limb weakness is more important when you're dealing with nulliparous prolapse because they can have spina bifida or any neural problems which are decreasing the tone of the uterus. Okay, so that's about the history of presenting illness. So, what are the differential diagnosis of mass per vaginum is another question which they can ask you. So, the differential diagnosis for the mass per vaginum are uterovaginal prolapse, fibroid polyp, congenital uterine, chronic uterine inversion, and congenital elongation of cervix. Now, we differentiate between each one of them. So, first and foremost, the fibroid polyp and chronic uterine inversion, external os is not seen. External os not seen. So, in the leading part, you cannot see the external os. Whereas in vaginal prolapse and congenital elongation of cervix, you will see the external os, right? Next, fibroid polyp. They also have history of increased blood, increased bleeding in between the cycles, intermenstrual bleeding, heavy bleeding, and dysmenorrhea. There can be all other associated symptoms like this. Next, when you see the mass and when you palpate, you can feel the cervical rim all around the mass. You can feel the cervical rim all around the mass. You can feel cervical rim around the mass. Next, between uterine prolapse, and congenital elongation of cervix, how do we differentiate? So, in congenital elongation of cervix, they have infravaginal portion of the cervix elongated. So, in congenital elongation of cervix, they have infravaginal part of the cervix being elongated. Whereas in uterine prolapse, what is happening because of the gravity, the cervix is trying to come down. The cervix and uterus are trying to come down, right? In the prolapse, because of the loss of the tissues and tone of the tissues is absent. So prolapse mein kya hoga? The uterus and cervix is coming down. So by gravity it is coming down. But what is happening to what are the ligaments doing? Ligaments are trying to pull it up. Ligaments are trying to pull it up. Uterus and cervix are trying to come down. So in this process, the supravaginal portion of the cervix gets elongated in uterine prolapse. So in uterine prolapse, it is the supravaginal portion of the cervix which is elongated. So because of this, what happens is when you are doing PV, because the infravaginal portion of the cervix is elongated in congenital elongation, when you do PV, you'll palpate deep fornices. Fornices will be deep. But here there is no deeper fornices. In uterine prolapse, there is no deeper fornices, right? So the differential diagnoses are polyps, chronic uterine inversion, and congenital elongation of cervix, and uterine vaginal prolapse for mass per vaginum. Next, they can also ask you the differential diagnosis for cystocele provided your patient has cystocele. So for cystocele is an antevaginal wall defect, right? So the differential diagnosis for the cystocele will be antevaginal wall cyst. So the mainly what we have as an antevaginal wall cyst is the Gartner's cyst. So how do we develop what is this Gartner's cyst is? So this Gartner's cyst is a remnant of the Wolffian duct. So if the Gartner's duct gets blocked, it forms a cyst. So Gartner's cyst is the remnant of the Wolffian duct. So this is again seen in the anterolateral aspect of the vagina. So you're mainly confused this with cystocele, but how do you differentiate between Gartner's cyst and cystocele? Now there is no point of Bartholin cyst. Don't bring Bartholin cyst here and unnecessarily complicate your DDs. Bartholin cyst does not act as a risk factor for cystocele because Bartholin cyst is a posterolateral cyst. So usually Bartholin will be present posterolateral, upper two-third and lower one-third junction. So Bartholin cyst is a posterolateral cyst, whereas Gartner cyst is a anterovaginal wall cyst. So how do you differentiate between them? So rugosities of vaginal mucosa are lost in the Gartner cyst. Vaginal mucosa will be tense and shiny. Margins are well defined. It is not reducible. No visible or palpable expansile cuff impulse in the Gartner cyst. In contrast to this, for cystocele, rugosities of vaginal mucosa are present. Rugosities of vaginal mucosa will be present. Margins are ill defined. So in Gartner cyst, they're well defined. Here they'll be ill defined. Gartner cyst is not reducible, whereas cystocele is reducible. Gartner cyst, no visible or palpable expansile cuff impulse, whereas here cuff impulse is positive. Here the cuff impulse is positive in the Gartner cyst. Okay, so these are the differential diagnosis for the cystocele. Right, now let's go further. So menstrual history, menopausal status is important. So usually you will see the prolapse in the menopausal women. So menopausal women, why? Because of the when in the menopause, because of the absence of the estrogen, so there'll be loss of the tone of the muscles, and that leads to the prolapse, right? So menopausal since 10 years at the age of 50 years. So she has been see, if I tell menopausal since 20, I cannot count there. So you can tell menopausal since 10 years. So she was menopausal at the age of 50 years. Previous menstrual cycle, she had regular flow, regular normal flow, and menstrual cycles also 3 to 5 days, around 20 to 30 days. Next. So, do we see prolapse in only in postmenopausal women? No, you can also see the prolapse in nulliparous women. Why do we see the prolapse in nulliparous women? So, nulliparous women prolapse is mainly because of neural tube defects. So, that is why you should know the sensation of the limbs and all, or any surgeries, like whether she has been operated for spina bifida or anything. So, nulliparous prolapse is because of the neurological deficit, because of neural tube defects or any other neurological deficits. Second, it can be due to connective tissue disorders. It is due to connective tissue disorders. Now, obstetric history is very, very important in your case. Why obstetric history is important is because the main risk factor for the prolapse is childbirth trauma. The main risk factor for the prolapse is childbirth trauma. So I broadly divide all the risk factors into childbirth trauma, raised intra-abdominal pressure, postmenopausal atrophy, and nulliparous. So, obstetric history will derive the childbirth trauma, which acts as a risk factor. Okay, now let's see the obstetric history. So, she is a paraphile living phi, so multiparous. Multiparous are at risk of developing prolapse. Multiparous are at risk of developing prolapse. Age at the marriage of 15 years. So when you are taking history also, you have to elaborate the obstetric history. So please listen the obstetric history properly. At the age of 20 years, she had full-term normal vaginal delivery at home, conducted by DAI, average weight baby, no history of prolonged or difficult labor, no history of instrumental delivery or fundal pressure, no history of perineal exercise in the postpartum period. Resume normal household work after postpartum day 7. So when you're taking obstetric history, you have to mention whether it's what is a mode of delivery. whether she had vaginal delivery or whether she had a cesarean section. Next, was it a institutional delivery or was it a home delivery? Home delivery, they're more prone for improperly repaired perineal tears. They don't give a episiotomy or they don't suture it. So they're more prone for the improperly repaired perineal tears, which can act as a risk factor for the prolapse, right? So repeated childbirth is a risk factor, improperly repaired perineal tears is a risk factor. Next, prolonged or precipitate labor both act as a risk factor. So prolonged labor for more than 18 hours exhausts the uterine muscles. Precipitate labor also leads to improper perineal tears. So precipitate labor is where all the three stages of labor, that is first stage, second stage and third stage of labor, merge into one and the baby is pushed out, right? So both act as a risk factor. Next, instrumental delivery or fundal pressure. So instrumental delivery or the fundal pressure, again, usually forceps has high chance of trauma to the entire perineum. So instrumental delivery or fundal pressure also act as a risk factor. A protective factor is to resume the perineal exercise in the postpartum period. So normally in the postpartum period, we are supposed to resume the perineal exercises. But if you have not resumed the perineal exercises in the postpartum period, again it acts as a risk factor. So resumption of normal household work after postpartum day 7, it means she's resumed back to her work, so she didn't give any proper rest for the perineal muscles to revert back to the levatranae and everything to revert back or to gain the strength. So when they resume back to their work pretty early, so they cannot gain the strength in the perineum and they have more chance of prolapse again. So you have to find out these histories. Now, this is only para 1 regarding the other pregnancies. So, now again, each pregnancy, no need to elaborate in so much because it will become time taking. So, you can, if all are vaginal deliveries, you can just put it like this also. First, elaborate one pregnancy in detail and then you can put it this way. Okay. So, P2 to P5, all full term vaginal deliveries at an interval of 2 to 3 years at home. They are conducted by DICE, average weight babies, no history of no history of difficult or prolonged labor, no history of instrumental deliveries or fundal pressure, no history of perineal exercises in the postpartum period. Routine activities resumed at around day 7 of the postpartum period. Last childbirth 12 years back. Now, no history of perineal exercises in postpartum period. So, what are the perineal exercises which they are supposed to do in the postpartum is Kegels exercise. So, they have to supposed to do the Kegels. That is, they have to contract and release the vaginal and perineal muscles. They have to contract and release the vaginal and perineal muscles. So, there's a small mistake in the last childbirth here. So, you have to ask according to your patients. So, last childbirth in this patient is around 25 years back. So, I'm just giving you a vague, right? Because her age is 60, so I think we can write as 30 years back. So be careful with all these histories also, guys, because these all small things can just tell that you have not taken the proper history, right? So be careful with these such histories also. So that's about the obstetric history, right? Next, coming to the past history. No history of diabetes, hypertension, tuberculosis, prolonged surgical or medical illness. No history of past treatment taken for prolapse. No history of blood transfusion. So, past treatment taken for prolapse is very important because uh, when I was a postgraduate, I got a vault prolapse. So, if you miss the history that she has already undergone a hysterectomy for prolapse and what you're dealing is vault prolapse, then again it will be like a full khichdi, right? So, first and foremost, you might be confused what I'm speaking. Vault prolapse matlab kya hai? After hysterectomy, whatever the vagina is left out, that can also come out. That is called as vault prolapse. Okay? So no history of diabetes. Why am I taking history of diabetes? So diabetes, because diabetic neuropathy can act as a reason for the prolapse because decreases the tone of the perineal musculature, right? Hypertension, tuberculosis, or previous surgical or medical illness. My treatment modality of when I'm planning the surgery, I should be aware of these things, right? Next, no history of blood transfusion. If the patient is anemic, again the hypoxia to the muscles can be the reason for the prolapse, right? Personal history: she's vegetarian, non-smoker, non-alcoholic, or no other addictions. Normal bowel and bladder habits. So as my patient is not having cystocele and rectocele, here no bladder and bowel habits. Now I really don't have any particular interest about the family history of this patient because this does not run in the families, right? So I've written not significant. So again, dietary history is important. Total calorie intakes is supposed, what is her total calorie intake and what is the total protein intake, and whether she's having any deficit, you have to write it, right? Now again, calorie intake, don't write idli chapati and all that. So write in brief, what is the calorie intake per day and how much is the deficit. Again, malnutrition leads to uterine muscle hypoxia of the tissues, leading to the prolapse. So malnutrition also acts as a risk factor for prolapse. So that finishes my history. Now coming to the summary of the history. So when you want to present your case in a beautiful manner, normally uh, you can summarize the history itself. For example, how do we summarize the history? A 60-year-old postmenopausal woman, para phi living phi, daily wage worker by occupation, comes with the complaints of mass protruding per vaginum since 7 years, which has progressed to the present size. Mass is reducible and increases with coughing and straining. It reduces on lying down. She has no difficulty in micturition or passing stools. She has a history of lifting heavy weights in her occupation. So, see this, the beauty of the summary. Everything which I wanted to know regarding the patient is there in this one paragraph, which I was explaining from the past 40 minutes. Right? So, your history should contain, summary should contain only the positive history, which gives me a gross idea what is about this patient. And if you're sometimes, पहले नंबर पे बहुत खींचा जाता है, but last में you don't have so much time to listen everything, so we just ask the summary. So you should be prepared in your brain what is the summary you want to present, or write it also, not an issue, so that you present the summary properly so that it can reach to the examiner, and that will fetch you more marks when your summary is beautiful. So I have started the summary with her age. Menopausal status I have mentioned because whether she's a premenopausal or reproductive or nulliparous or postmenopausal, we know that high parity is a risk factor, so I have included that. I told you daily wage worker was also accounting for the positive history that is why she might be going into the prolapse, right? So that I have mentioned. Then regarding the mass, I have told the size to the present size. And I mentioned the severity of the mass, whether it is reducible or not reducible. And I've mentioned that she does not have any cystocele or rectocele. And I mentioned that she has lifting heavy weights because that is one of the major reason why she's having prolapse, right? So after the summary, the general physical examination. So let's start with the general physical examination. So no need to write, patient is conscious and all that. So you can just tell, you can just see most of the time we always have this habit of telling she's oriented to time, place, and person. So you don't require to elaborate in such way. You can just tell she's conscious and oriented. She's moderately built and nourished. Her height is 158, weight is 62, BMI is 24.84. Thyroid normal, breast normal. So BMI of 24.84. So BMI, if it goes is beyond 25, it would have landed up in overweight, right? Beyond of 25, it would have landed up in overweight. So here she is a normal BMI, yes. No pallor, edema, and extras. Cervical inguinal lymphadenopathy is not present. Oral hygiene is fair. Her pulse is 82 beats per minute, regular, good volume. All peripheral pulses felt. Blood pressure 120/70, right arm in sitting position. Respiratory rate 18 beats per minute, febrile. I would prefer not telling no radial or radiofemoral delay, but in this case, but in prolapse, you should be mentioning this provided your patient is reproductive age or anything. Why is it important to mention no radioradial or radiofemoral delay, especially when you are dealing with nulliparous prolapse? So you're trying to rule out the connective tissue disorders like Marfan's. So there you have to tell this, mention this, no radioradial or radiofemoral in Marfan's and all. Okay. So systemic examination, cardiovascular system, S1, S2 heard, no murmurs. Respiratory system, normal vesicular breath sounds, bilateral air entries equal, no added sounds. Neurological examination is important here, especially again, where is neurological examination important? See, as I'm giving you a case, I've incorporated everything. But if you have an old lady, no need to elaborate the neurological examination in this much. Okay? If you have a nulliparous woman or a reproductive age woman presenting to your prolapse, there this neurological examination is very important because you're trying to rule out the connective tissue disorders and neurological deficits, right? So conscious oriented and cooperative, normal gait, lower limbs joints are normal range, muscle good tone and power, reflexes are normal, so you have to mention all this. Sensation, touch, cold, prick, appreciated, Babinski reflex normal, and spine normal. So examining the spine is also very important because on examination of spine you can get the neural tube occulta bifida. You know, you can get that two dimples with some tuft of hair, or you can get the mass. So you should be examining. But again, I repeat, this is all not important in a 60-year-old with prolapse. But I'm telling you here, just if you have a nulliparous prolapse, you might require to speak about all this. For 60 year, don't mention, not required. Okay? So per abdomen, again, you don't have much positive findings here. So on inspection, umbilicus is central and inverted. No scars or dilated veins. Striaalbicans seen. No visible swelling. So mass per abdomen can act as a risk factor or can push our prolapse outside, right? All quadrants move equally with respiration. Hernial sites are normal. On palpation, no local rise of temperature, no tenderness, guarding, or rigidity, no mass palpable, no hepatosplenomegaly. On percussion, normal tympanic note, and on auscultation, vowel sounds are heard. So next is the local examination and per vaginal examination, per speculum examination. That is important again, and again as an undergraduate, they might sometimes allow you to examine it, or they might directly give you the findings, right? So till here, what we have discussed regarding was the history. So further, what we are going to discuss is regarding the how do we examine, how do you differentiate rectocele, enterocele, how do you proceed further for the management, how are you going to investigate her. So these are the points which we will be speaking the rest of the session, right? So now let's see the findings of local examination. I'm examining the patient in the dorsal position. So what all are the points which you should observe in the local examination? So that's also important for us. So normally we have to see whether the mass is lying inside or lying outside. So in this patient, the mass is lying outside the introitus. If in case the mass is not lying outside, then you can ask the patient to strain. If after straining also if the mass doesn't come, then you can ask her to do so straining you can ask her to do valsalva or coughing, right? Even if after that also if the mass does not come out, you can ask her to ambulate. So sometimes the mass comes out on ambulation, right? So you have to first to know the appropriate whether the mass is outside or whether the mass is still inside. So to know the appropriate position of the mass, you have to ask the patient to strain or ambulate, right? So here in my patient, the cervix is lying outside the introitus, and you have to describe few points on the external genitalia. The mons pubis is normal, so you can tell hair is trimmed with normal distribution, labia majora is normal, external urethral neatus is normal, clitoris is normal, forcetus no tears and scars. If you're not very confident about all this, you can just tell external genitalia. There is a cervix lying outside the introitus. Now, why am I telling this is cervix lying outside the introitus? Is yes, I can see the external os. As I'm able to see the external os, I am telling cervix is lying outside. I'm not telling mass lying. I'm telling cervix is lying outside the introitus, right? So usually you have to examine the patient on in with full bladder initially. Why? To check for the stress incontinence. So when the patient is in full bladder and when you ask the patient to cough or laugh, if there is small amount of urine coming out, that means you are dealing with stress incontinence. So on maximum straining, there is no, with full bladder, there's no urinary incontinence in these patients. Then on maximum straining, I told you the patient should strain only, then you will be able to observe everything. With empty bladder, so rate all empty bladder. So cervix lying outside the vaginal introitus and it is hypertrophied. So what all changes will you observe in the cervix? So whenever you have a long standing prolapse, there are many changes which we can observe. So there will be loss of rugosities. So whenever there is a mass outside, you have to observe if there is any hypertrophy, whether rugosities are present or not, right? Where is the cervix? So I'm telling you first what are all the points which you have to observe. First point which you have to observe is whether cervix is seen or not. So cervix you have to see whether the mass is hypertrophied, whether there are any keratinization patches, right? Or whether there is any loss of rugosities. So these are all the things which you have to observe, right? So as I've told here, the anterior vagina, and so here the cervix is lying outside the introitus and it is hypertrophied, and I can visualize anterior and posterior vaginal wall prolapse. There is loss of rugosities on both anterior and posterior vaginal walls. Vaginal walls are healthy and genital hiatus is widened. So these are my findings looking on local examination, right? So I can see the cervix. There is. Do you see any rugosities? No, there are absolutely no rugosities. So I'm telling there's loss of rugosities, right? And how do you see that there's a gaping of the hiatus? So genital hiatus is widened, right? But vaginal walls looks healthy on either side. There is a small keratinization patch if you can observe. So I have to describe this patch also. So there is 2 into 1 centimeter irregular shaped patch which is dark pigmented and hyperkeratinized and is present at 10 o'clock. So and it's non-tender with normal sensation. So you have to describe about the patch also. Next you have to also mention whether it is reducible or irreducible. So here this mass is reducible. So this mass is reducible. Sometimes you can also have irreducible prolapse. So many times they ask you what are the reasons for this irreducible prolapse. So the reasons for irreducible prolapse. So irreducible prolapse is also called as incarcerated prolapse. Incarcerated prolapse. The reason for this irreducible or incarcerated prolapse is one, because it tells that this is a long standing prolapse. So because of the long standing, there is edema, hypertrophy, and congestion in the prolapse. So because of the long standing, there can be edema, hypertrophy, and congestion, which is preventing it to go back, right? Next, there can be some associated conditions which are preventing it to become incarcerated or irreducible. So the associated conditions like there can be a big fibroid or there can be cancers, cervical cancer or endometrial cancer. Now, how does this cancer make it irreducible? So anything which is causing fibrosis and preventing it to go back can also result in incarcerated or irreducible prolapse. So cervical or endometrial cancer causing fibrosis, and another thing which we can cause fibrosis is endometriosis. So endometriosis causing frozen pelvis or radiotherapy treatment given or any infections. So all these can also lead to incarcerated or irreducible prolapse. Now, how do you treat this edema or congestion? So this edema or congestion you can give magnesium sulfate plus glycerin. Magnesium sulfate plus glycerin pack. So that will help in reducing the edema. So these absorb the water from the edematous prolapse and they help in reducing the edema, and they can some way, some extent, make it reducible. So this is one important point. So this is how you are going to describe the local examination. So what are all the points you are which are important for the local examination? So everywhere I'm telling you as a points, so remember them as a points itself. So where is the cervix, whether the leading point is cervix, because if leading point is not cervix, then it is not prolapse. It might be your fibroid polyp, or it might be chronic uterine inversion. So to call it as a prolapse, you should see the cervix if it is a uterine prolapse, right? So tell about the cervix. Next important, these are all not important for us. Next important was whether there is any stress incontinence. Next, whether the mass is reducible or irreducible. Then what are the changes which you are observing in the mass? So is the cervix hypertrophied? Whether the walls are healthy or not. Next, whether there are any presence or absence of vaginal rugosities. So presence of rugosities. So these are the important things which they can ask you. These are the important points which they can ask you on the local examination. Coming to examination of the prolapse, a very important. Before I start with the examination, you should be knowing the staging of prolapse. The outdated staging, or the famous staging which as an undergraduate every examiner expects from you, is the Shaw's classification. So, but what is the staging which is universally accepted now? The universally accepted staging is POPQ, which I'll be teaching you now. But what examiner might expect from you to answer is Shaw's classification. So in Shaw's classification, he divides the anterior vaginal wall defect, posterior vaginal wall defect, and uterine prolapse. So uterine prolapse. So normally the external os lies at the level of ischial spines, and internal os is at the upper border of pubic symphysis. But any descent of the uterus or the cervix, we call it as uterine prolapse. So the grades of uterine prolapse are: the first degree is descent of the cervix into the vagina. So first degree is only the cervix descent into the vagina. Second degree is cervix up to introitus, cervix into the up to the introitus. Third degree is cervix outside the introitus. Procedentia, or the fourth degree, is descent of all of the uterus outside the introitus, including the fundus. Now, one very famous question which they can ask you is, how do you differentiate between third and fourth degree? Because in both third and fourth degree, the cervix is outside the introitus. Then how do you differentiate between third and fourth degree is one of the famous questions which they can ask you. Very good. I hope you have all answered correct. So, in both third and fourth degree, cervix is outside the introitus. 100% correct. Right. But when you try to, let's imagine that this is the cervix. This is the prolapsed uterus or the cervix. Okay. So this is the cervix which has come out. So this is third degree because some fundus is still inside the vagina. Fundus is still inside. And this is the fourth degree because fundus has completely come outside. Okay. Now, when I'm trying to palpate the third degree, if I'm trying to palpate around the mass, my both hands are not touching each other. When I'm trying to palpate with my both hands are not approximating, and neither I'm not able to go above the swelling. But when it is fourth degree or precedentia, when fundus also has come out, when I try to approximate by my both fingers will approximate each other, and I can get above the swelling. I repeat. So how did we differentiate? So when the mass has completely come outside, I can go above the swelling, I can approximate my fingers. Whereas in third degree, still some part is still inside. अभी भी थोड़ा inside है. तो उसकी वजह से क्या होगा? You cannot approximate both of your fingers. neither you can get above the swelling, right? So third degree is, so this is called as, so you can differentiate between third and precedentia by, so in precedentia you can get above the swelling, you can get above the swelling, and you can approximate both your fingers. So that is called pinch test. So pinch test is also positive in the precedentia, right? Now in the management, is there any difference in the management of third and fourth degree? There is no difference in the management in third and fourth degree, but in fourth degree, the gynecologist, the operating surgeon should be more careful. Why? Because at the cervico-vaginal junction, you know that there is ureter passing. So here the ureters would have literally come down very low. There is high chance of ureteric injury. So in precedentia, as the ureters have come down along with the cervix, so there's high chance of ureteric injury. So there should be very careful dissection in precedentia. Similarly, we have antevaginal wall classification, antevaginal wall defect also. So if upper two-thirds of the antevaginal wall is defective, it is called cystocele. Lower one-third is defective, you call it as urethrocoele. Posterior vaginal wall, upper one-third defective called as enterocele, that is pouch of Douglas herniating. Middle one-third defective is called rectocele. Lower one-third defective is called lax perineum or deficient perineum. So you can observe here, bladder bulging into the vagina is called cystocele. See, this is the intestines bulging out into the vagina. So this is called enterocele. So rectum bulging into the vagina, rectocele. This is uterine descent, which we call it as uterine prolapse. The last image is uterine descent, which we call it as uterine prolapse. So here if you observe this picture, the middle picture. So in the middle picture, uterus also has descended down. You also have bladder pouching into vagina. You also have rectum pouching into the vagina. So this is a rectocele, cystocele and uterine descent. So usually we can have combinations. Now, do you know why we can have a combination is normally the pelvic floor and you actually, we are very, matlab, my undergraduation also I got prolapse as an exam case. My post graduation also my exam case was prolapse. So prolapse is something very, very common in India. Usually Asian and Africans, we are having type 3 collagen, guys. Our pelvic support is mainly by type 3 collagen. And genetically, we have defect in this type 3 collagen. So pelvic support is mainly type 3 collagen. Asians and Africans have genetic defect of this type 3 collagen. That's why as the estrogen is lost after menopause, so we are more, that postmenopausal atrophy is more prone for this vaginal descent also, vaginal wall prolapse also, and uterine descent also. But ideally, I told you that what is the classification which you should know? It is the POPQ. So there are many questions which they can ask you in the examination. One step by step I'll go for. Okay. So POPQ is the universally accepted classification. It's a little complicated, but I'll try to make it as simple as possible for all of you. So what does this POPQ stands for? It is pelvic organ prolapse quantification. Now, first question arises is basically this is the same as SHOS, but here you're going to have a proof that actually there is a prolapse by measuring how much is the prolapse. And how does it help me? It helps me to assess my how well I have done the surgery. So this helps me to assess how well I have done the surgery. How? So you're going to quantify the prolapse before surgery as well as you're going to quantify the prolapse after surgery. So when you're going to quantify the prolapse after surgery, you should see the improvement. So it is, you should see the improvement. So then it tells that yes, you have done a good repair. So the findings, whatever we are doing, they should have been whatever before and after what we have done. You should see the difference in the walls measurements. So it helps us to know the outcome of the surgery. And it is a documentation also you're having, no? So it helps us for outcome for surgery. So there is a grid here which we use to measure. So A, B, C, G, H, P, B, D, A, B, T, B, L, and D. Yeah, don't worry what I'm writing. Just give me 1 minute. I'll explain you. First, I'll try to explain each what is this grid and what are the things which I'm writing here. Then we will take an example and we will do, as well as I've kept the patient findings also here just for you to understand. But I'm not doing a live how to measure here. Okay, but we have the images. So now if you take in this first compartment is about the anterior vaginal wall. Second compartment is regarding the perineum, the lower perineum. The third compartment is regarding the posterior vaginal wall. So AA is the anterior vaginal wall. BA is also on the anterior vaginal wall. C is cervix. GH is genital hiatus. PB is perineal body. D is posterior fornix. AP and BP are posterior vaginal wall. TVL is total vaginal length. ठीक है. Now, सबसे पहले we have to measure the genital hiatus and perineal body. Okay, I'll try to draw a diagram myself instead of this diagram. Cervix. Yes, I'm little bad in the diagrams, but just I am definitely sure that you will understand this picture. So I am trying to not do the anti version and all because to make it simplified. So let's take this as a bladder. This is the uterus and cervix and vagina, and this is the rectum. सबसे पहले I am going to discuss what is genital hiatus and what is perineal body. So from the external urethral meatus, let's keep urethra little near. From external urethral meatus to the posterior vaginal wall, this is called as genital hiatus. This is called as genital hiatus. GH in the grid. So I hope you remember the grid. So this is called as genital hiatus. Next, from posterior vaginal wall to the rectum, to the midway of the rectum, this is called perineal body. This is called as perineal body. So from external urethral meatus to posterior vaginal wall is genital hiatus. From posterior vaginal wall to the rectum is the perineal body. So this is the two measurements which we have discussed now, that is GH and PB. So in the grid we had in the middle GH, PB and total vaginal length. Next AA, BA, C, AP, BP, D. Next most important point, this entire classification, this entire measurement is taken with respect to the hymen gaze. It's taken with respect to the hymen. Okay, so anything above the hymen, so your reference point is hymen. Reference point is hymen. ये बहुत important point है. ठीक है. So anything above the hymen. So if your descent, the cervix is above the hymen, so you are going to write it as plus. Sorry, if it is inside, you have to write it as minus. If it has come outside the hymen, then you are going to write it as plus. If the leading point is inside, then you're going to write it as minus. If the leading point is outside, then you have to write it as plus. This is the point number 1. Next, you understood what is genital hiatus. You understood what is perineal body. Total vaginal length is from the posterior fornix till the hymen. From the posterior fornix till the hymen is the total vaginal length measurement. That's also simple. So you have to reduce the entire prolapse and you have to measure the from the posterior fornix till the hymen. Okay. C is cervix. C is cervix. So cervix again from hymen to the leading point on the cervix. So entire cervix might be outside, but which is the leading point? So the leading point of the cervix till hymen is C. D is posterior fornix. So from posterior fornix to the hymen is the D. So normally TVL, and if it is normal uterus, TVL and D can coincide, but yes, it can keep changing also, right? With the prolapse, the findings can change. Now, what is AA and what is BA? They are on the antevaginal wall. So now we have understood from this picture, what all we have understood from this picture, what is genital hiatus, what is perineal body, we have understood what is total vaginal length, we have understood the posterior fornix is given the D, and we have understood that cervix is given the C, right? Now we'll try to understand what is AA, BA and what is AP, BP. So let's take one more image. First and foremost, AA is 3 centimeters proximal to external urethral meatus. So this is the external urethral meatus, 3 centimeters on the anterior vaginal wall. So from external urethral meatus on the anterior vaginal wall, 3 centimeters. So this is the AA. This is AA. So this usually should be I plus 3 to minus 3. This should be either plus 3 to minus 3. So if anything is inside, it is minus. If anything has come out, it is plus. Now, next, AP is also similar. It is 3 centimeters proximal to hymen on the posterior vaginal wall. So I'm telling AP, right? Why is AA taken only 3 centimeters proximal to external urethral meatus? Because this is the junction of utrovesical junction. This is the uretrovesical junction, not utero. This is the uretrovesical junction. The angle of urethra and bladder is at this level. That's why this is the AA point. Now coming to the BA and BP. These are the distalmost points on the vaginal walls after straining. So these are the distalmost points above the hymen on the vaginal walls after straining. So usually, if there is no prolapse, AA and BA and BP should coincide. So normally when they don't have prolapse, so this is the distalmost point on the anterior vaginal wall. Even BP is the distalmost point on the posterior vaginal wall, right? So normally if there is no prolapse, AP and BP and A and BA should coincide. So AA and BA, AP and BP should be coinciding. Now how to measure AA and AP? This is only the little confusion I have observed in students. First, you should reduce. There are only 2 measurements you have to take full reduced. So you have to reduce the entire prolapse, and then when you're measuring from the hymen to the posterior fornix, that will give you total vaginal length. So total vaginal length, how are you measuring? You have to reduce the entire prolapse inside. Okay. And then the distance from the hymen to the posterior fornix will give you the total vaginal length. Okay. But your C, D, these are taken in the normal position of the prolapse. So if it has come out, there only you have to measure. अगर फ्रॉम हाइमेन से वो बाहर आया है तो माइनस लेंगे, ठीक है। सो नेक्स्ट, this AA and AP also, when you have reduced, you have to mark. So you have to reduce and then 3 centimeters proximal to external urethral meatus. So it's a fixed point. So you have to mark this and then you allow it to come back to whatever position it was. Then from the hymen, where is this located? Where is this AA point is located? That will actually give you the AA, how many centimeters it is. If AA has come out, it means you'll write -1 like that. Now, let me give you one example. Okay. In the first picture which we are having, so from the external urethral meatus, 3 centimeters. So first, cervix. So cervix is here. This is the leading point of cervix. So this is the hymen. So let's try to write everything for this picture. So I don't have in this picture the genital hiatus and perineal body. So let's genital hiatus and perineal body is easy to measure, right? So we don't have, and we cannot do the total vaginal length also here. Yes, because you have to reduce the entire mass and then take the measurement of total vaginal length, right? So that's why I'm not writing these three. So first start with the cervix. So see, so this is the hymen. So from hymen, where is the cervix? This much will be the C measurement. So if you are observing, it will be some around 3 centimeters. Let's take it as. So is it inside or outside? It is inside. So you are going to write it as -3. Similarly, from the hymen till the posterior fornix. So this looks around 5. So it is -5. So AA 3 centimeters from the posterior fornix. Sorry, 3 centimeters from the external urethral meatus. So here is the AA. Right, so this is 3 centimeters. So here he has given. So that is again located normally -3. But see the distal portion, it is not coinciding. Distal portion is somewhere here. Right. So from here to distal portion, you again have to measure and write it how much ever it is, like -4 or whatever it is. Right. Similarly, AP is 3 standard. BP, how much it has gone inside? It is distal to AP. So from the hymen, again, where it is you have to measure and write. So for example, -4, this is -3, -4. So that's how you have to write. That's how you have to measure and write. So I hope you understood. I'll repeat once again so that if you have any queries or anything, it can get solved by this. So I'll repeat once again. First, genital hiatus is from external urethral meatus to the posterior vaginal wall. From posterior vaginal wall to the rectum is the perineal body. So this is GH and PB are clear. Total vaginal length is after you have reduced the entire prolapse inside. Then from the hymen to the posterior fornix is the total vaginal length. Next, AA is from, and cervix is from the hymen to the leading point of cervix. From the hymen to the leading point on cervix. D is from the hymen to the posterior fornix, wherever the posterior fornix is. The reference point is hymen. Anything inside the hymen are given minus. Anything outside the hymen are given plus. Okay. AA is 3 centimeters proximal to external urethral meatus. BA is 3 centimeters proximal to the hymen on the posterior vaginal wall. AP is the most distal part on the anterior vaginal wall. BP is the most distal part on the anterior vaginal wall. Simple. Henna. Now we'll see in our patient. So this is the prolapse which we have in our patient, right? So here, first I have reduced and I have measured the AA, 3 centimeters proximal. So when it has come out, the AA is coinciding to the hymen. A is coinciding to the hymen. So I have written it as 0. When it coincides with the hymen, you have to write it as 0. Next. But now when it is in the normal prolapsed, so A was coinciding, but the distal portion is still here of the anterior vaginal wall. This is the starting point. So this is the hymen and this is the distal point of the vagina. So if you're seeing from here to the distal point, it has come out. So plus 3. So it has come out, it is plus 3. So BA is distal most after maximum strain. After maximum strain, the distal point. So after maximum strain, I repeat, guys, I somehow feel probably AA and BA might be a confusion to all of you. So I'm repeating this again. So AA is 3 centimeters proximal to external urethral meatus. So what you should do? You should first reduce this inside and then mark AA inside. And then you let the prolapse come out. Then where is that mark to the hymen? Should write AA. So here they are coinciding. My marking and the extra hymen level is same. So I have written 0. मैं फिर से एक बार रिपीट कर रही हूँ. पहले आपको क्या करना है, उसको अंदर ढकेलो. द मास को ढकेल दो अंदर. पुट द मास इनसाइड 3 centimeters from the external urethral meatus. Mark that will be AA. Okay, then let the prolapse come out. So then you will see that AA is going, the distance of AA mark which I have drawn to the hymen, you should write as AA. You should write how much ever it comes. Okay. Now BA is the distalmost point on the post and the antevaginal wall from the hymen. So this is BA. This is the distal point on the antevaginal wall. So how much is that from the hymen? 3 centimeters. So plus 3. As it has come out, I'm writing plus 3. If it would have been inside, I would have written minus 3. Now next is C. C is cervix. C is cervix. So the leading point of the cervix. So this entire is the cervix, but this is the leading point. So the leading point of the cervix from the hymen will give me C. So it is coming 5 centimeters. See, 1, 2, 3, 4, 5. So that's why I've written 5 centimeters. And as it is outside, so you've written plus 5. है ना? Similarly, genital hiatus and perineal body, though I cannot show you, but it is from urethra. So from the urethra to the posterior vaginal wall is the genital hiatus. From the posterior vaginal wall to the rectum is the perineal body. So we will write them later. Next, AP. So AP was what? 3 centimeters distal to 3 centimeters proximal to the posterior hymen on the posterior vaginal wall. So that was inside itself. So it is minus 3. But BP, if you measure, it is little come out. Distal point has come out. So again, you have to measure from the hymen. Where is the BP? So it is plus 3. D is posterior fornix. So D, as how it is, like that only you have to see till where you can go inside. So here D is also coincide. D is also only 3 centimeters inside the hymen. So D is posterior fornix, which is inside. But it is how much from the hymen? 3. So minus 3. It is inside, so minus 3. So genital hiatus is from the urethra to the posterior fornix. It is coming 6. Perineal body is coming 2. Total vaginal length, you have to completely push everything inside. You have to completely push everything inside. And then you have to measure from the hymen, that is the introitus, to the posterior vaginal wall. Sorry, to the posterior fornix. So we have pushed everything and it is coming almost here to here. So it is 9 centimeters. Total vaginal length is 9 centimeters. So everything which has come out indicates that it is a prolapse. So here BA is come out. So this is an antevaginal wall defect. So it means that there is a cystocele. C, cervix has come out. So much it has come out. So there is a uterine descent. C plus में है मतलब cervix has come out. So it's a uterine descent. BP, posterior vaginal wall also has come out. So it is a rectocele. See, if posterior fornix also would have come out, then I would have told this is an enterocele also. Okay. Then how do you describe? Then what is the description which we give stage wise? So staging of the POPQ is very similar to your what do you say? Shaw's. So 0 means no prolapse demonstrated. 1 means the most distal portion of the prolapse is greater than 1 centimeter above the level of the hymen. So this C should have come in the minus if it should be above the hymen, right? 2. The most distal portion of the prolapse is less than 1 centimeter above or below the level of the hymen. Either it is 1 centimeter less than 1 centimeter above or below. 3. The most distal portion of the prolapse is greater than 1 centimeter below the level of the hymen but protrudes no further than 2 centimeters less than total vaginal length. So here it has come 1 centimeter below the level of the hymen, but it has protruded no further than 2 centimeters less than total vaginal length. For example, here C was plus 5, TVL was 9. So C and TVL are not equal. So that is why it is in 3. So 4 is complete eversion of the total length of lower genital tract. The distal portion of the prolapse protrudes at least 2 centimeters less than total vaginal length. So if total vaginal length is 9 and your distal portion, that is the leading point of the cervix, is around 7 or 8, then it is a stage 4 or precedentia. So as it is not like that, so that's why what did I write? POPQ stage 3 with leading point C. Understood? Hopefully. Now again, everyone don't ask this, so it depends on college to college. If they ask, definitely you should be in a position to answer. I hope I simplified it. If any further queries, always feel free to ask in the DBMCI group. I'll be always either in the Facebook or Telegram. I'll be definitely helping you to make one more video and posting. Okay. Now coming to the pervaginal. So cervix feels smooth, uterus normal size, retroverted, levitrine tone also you should see. So you hold the levitrine and ask her to close the pelvic floor. So if you are able to feel it and if you are feeling your fingers are getting clenched, then it is a good tone, right? Per rectal examination is also very, very important in prolapse. Now, why do you do the per rectal examination? So, actually speaking, I should have spoken at the level of per speculum itself to differentiate between the rectocele, enterocele to identify. So, per speculum itself is also important to differentiate between your enterocele or rectocele or cystocele, everything. So first and foremost, when you're doing per speculum, for if you see a bulge in the anterior wall, it is a cystocele. Similarly, on per speculum, if you see a bulge in the posterior wall, it is a rectocele or enterocele. Now, what do you do for per speculum, enterocele or rectocele is, normally you always hold the anterior lip of the cervix. So here, these are non-pregnant. So with valsallam, you will hold the posterior lip of the cervix. So you have to hold the posterior lip of the cervix, pull it up, and in the posterior fornix, you should see a bulge. If you are seeing a bulge in the posterior fornix, then it is enterocele. Now once you come down, keep coming down. If you see a bulge below that, bulge in the posterior vaginal wall, middle, then you call it as rectocele. Now, how do you differentiate? How can you tell on rectal examination? So in rectal examination, so you should do per rectal, and if you're able to hook your finger, then it is rectocele. If you're able to hook your finger, then it is rectocele. So per rectal, if you're able to hook your finger, it is rectocele. Okay. Next, we also do rectovaginal examination here. So rectovaginal, one finger in the rectum, one finger in the vagina, like this. Okay. So rectovaginal examination. In rectovaginal examination, you should feel the rectovaginal septum, whether it is thinned out. So you can feel the thinning of the rectovaginal septum. Then you should feel the perineal body also. So perineal body thickness you can measure. Normally the perineal body is pyramidal in shape. Then they can ask you everything about perineal body. It is usually 4 into 4 centimeters, guys. So what are the muscles which get inserted into the perineal body? So there are 4 paired muscles and 2 unpaired muscles. The 4 paired muscles are levator ani, superficial and deep transverse perini, and the bulbospongiosus. And 2 unpaired muscles are sphincter urethrae and external anal sphincter longitudinal coat. External anal sphincter longitudinal coat. Right? So you can remember it with a mnemonic called blessed, guys. So you can remember it a mnemonic called blessed. Sorry, it is not sphincter urethrae. It is the external anal sphincter and longitudinal bands of rectal muscles. Longitudinal bands of rectal muscles. So external anal sphincter and longitudinal bands of rectal muscles. So you can remember it as blessed, that is bulbospongiosus, levator ani, external anal sphincter, superficial transverse perini, deep transverse perini. I think we have covered everything, no, in the blessed. Bulbospongiosus, levator ani, external anal sphincter, superficial transverse perini, and deep transverse perini. So there's one E which is extra, right? So, and longitudinal bands of rectal muscles also is included. Okay. And when you keep vaginal examination, when you do vaginal examination for in the posterior vaginal wall, so when you keep your finger and you ask the patient to cough, if you're able to feel the bulge on the pulp of your finger, then it's the rectocele. If you're feeling the bulge touching your finger, tip of your finger, then it is enterocele. So when you're doing rectovaginal and you're asking the patient to cough, if you're able to feel the bulge to the pulp of your finger, it is a rectocele. If you're feeling the bulge tip of your finger, it is an enterocele. This is also one more way. But most important are these. So on posterior vaginal wall, rectocele is confirmed. Rectovaginal septum is thin. Anal sphincter tone is good. Perineum is thinned out.